Welcome back to another episode of Health Matters with Lynn Szabo. And I will be your host today, Heather.
Yeah, hi. So I'm a PA working in the community, as a lot of people know. And today's topic is, well, it started off as perimenopause, but kind of interesting when I went into the medical libraries that I have access to and kind of searched for perimenopause. That's not really a word that medicine uses, although we use it in discussing those changes with the women patients that we have. So what we do, we just call it menopause, I guess, but we look at it on a continuum. I think that's what's important.
What do you mean a continuum?
A continuum that kind of starts with stages. So the first stage is reproductive. So that's women who are theoretically able to get pregnant and have children. Okay. But the next stage, which I think corresponds to perimenopause, is called menopausal transition, which it seems to me like really, guys. But
menopausal train wreck.
Yeah, transition, which is variable, and it kind of starts about 1 to 3 years before actual menopause. Now, actual menopause happens in biologic females from age 43 to 52, with most menopause happening on the average at 51, which ironically corresponds with my experience. But
why such an age range difference? What would cause that?
What would cause that? Well, I think what's diversity in genetics, probably family history. I speak a little bit to that at the end because part of it could be, other things that affect hormones in a person, like surgical menopause, for example.
Okay,
that's different. But early menopausal stages are initially 2 to 6 years after the last menses. Okay, so we define menopause, you don't really need lab tests. All you need is not having a period for a year. So no bleeding for years is by definition menopause.
Even spotting, just zero.
Zero. So, and then...
just for clarification. So 1 year, no nothing, and that's menopause.
It. You've crossed the line.
Okay.
So if you have bleeding...
anything prior to that is perimenopause?
Well,
is that the continuum?
Yeah, that's kind of the continuum, but that's not the language they use.
Okay.
Yeah. So they see it as an ongoing process. It's subtle, okay, and I think you'd have to live in medicine to understand why it's so ridiculously subtle. But and then there's kind of early menopause, so after menopause, early menopause, which lasts about 2 to 6 years after the last period, and then late postmenopause, which is 7 years after to lifelong. Okay?
Okay.
So if somebody had spotting, if somebody had no menses for a year, for no obvious reason, like childbirth wasn't part of it or they weren't on any hormones and they didn't have a endometrial ablation, which is a destruction of the lining of the uterus so that somebody can't have a menses, and then they all of a sudden start spotting, that is a super red flag.
Okay.
In medicine, and that needs to be discussed with that person's provider.
Okay.
Okay. But these different symptoms have these different stages have different symptoms. So the classics are, and I kind of stuck with the classics, hot flashes, sleep issues. That was terrible for me. Mood swings, and they start happening about 1 to 3 years before menopause actually happens. We'll get to why women think they happen earlier.
Okay.
Because I think that's fair to address. And then after menopause, it kind of goes away from hot flashes and sleep problems and mood swings to actual kind of vulvar atrophy, which is a huge, big problem in women.
Yeah.
Huge, big problem, and that's a whole show in itself. But that causes problems with urinary tract infections that can become so horrible that they're untreatable and that people actually can die from urosepsis.
Oh, that doesn't sound pleasant.
Yeah, because they haven't had something simple addressed, and then it just kind of snowballs.
Wow.
So these are life-changing, and they're frustrating, and they're highly treatable, which is super cool. There's treatments for hot flushes. There's treatments for mood swings. And there's treatments for the sleep.
Okay, so what would those treatments be? And those are the typical symptoms of menopause.
Right.
And perimenopause,
right,
which isn't a medical thing that we just refer to it as. What are the treatments for that? And then what are the non-typical symptoms that women can experience?
Okay. So the first thing is the treatments. They're kind of varied, and it kind of depends on what an individual woman's health situation is. So some things are more useful and safer than other things. So that's a discussion with a primary care person. But in general, and I think some women would take offense to this, but antidepressants. So they're not saying that the woman's crazy. They're not saying that what she's feeling is, just a mental illness. What they're saying is, for some reason, these medicines seem to help people, and they don't really know why. I think that now is a good time for an aside that hormones, when somebody comes into the exam room and they're worried about their hormones, and I'll put air quotes on that, then the provider just kind of looks at them and looks puzzled. We have thousands of hormones that are going on at any particular time in our body. And I think what women are talking about is and we'll get into it in a minute, but is, a particular set of probably about 4 or 5 hormones. But what the provider thinks when they hear that is, what? That's like thousands of tests, probably not necessary. And then I think that's a point where women get written off, okay? Because they don't know the question they're asking is super overwhelming. So if you're a woman out there and you have this concern, don't go in there and say, I want to talk about my hormones. Say, I have a concern about hot flushes or insomnia or how I might be, physiologically approaching menopause. How can we sort this out, and what can medicine offer me?
So it's important to tell your doctor what it is, the symptoms you're experiencing, to narrow down what it is they're looking for.
And can I say it's important for the provider to also not click out at that moment and start to ask questions about, well, what do you really mean by that? Have you been reading something that means you think we should go in this direction? Or what's affecting your life to the point that you're seeking help? And then I think that conversation goes much better.
Good to know. Thank you.
Yeah, because these are life-changing and frustrating. I think women sense changes earlier. And when I was looking into how the hormones, air quotes again, how they change just before, maybe in the years before somebody is directly premenopausal. I think women sense that. And what's kind of happening is hormone levels of estrogen, progesterone, luteinizing hormone, and follicular stimulating hormone are really high when women are in their reproductive years, because that's the goal, right? The goal of this whole system at that point is to reproduce. And then they kind of settle down in midlife. And I think women feel that.
Do you have an age for midlife and what you're referring to?
Yeah, I think we're talking about early 40s to late 40s. But in some women who go through menopause sooner, it could be the late 30s.
Does that correlate to being younger when you start your period? To starting menopause earlier?
It could, but I also think there's probably a genetic component. It's way more, I don't think you can pin one risk factor for it. I think it's way more complicated than we think.
It does sound very complicated.
Yeah. So these 4 main hormones, let's touch on those a little bit. So luteinizing hormone is the message from the brain to the ovaries to put an egg out. Okay. The brain and the ovaries are kind of like leading the whole menstrual cycle. So luteinizing hormone comes from the pituitary, and the message is to the ovaries, it's time to do it, release an egg. And then follicle stimulating hormone is the message from the brain to kind of like turn the volume up for luteinizing hormone. Yeah, let's get on board. Let's make that egg. Go team, go. And then luteinizing or follicle stimulating hormone has another job too that's really important. It supports the production of progesterone, which is one of the other hormones. Progesterone supports an early pregnancy by building up the lining of the uterus.
Okay.
Okay, so that's called endometrial tissue. That's when it's sloughed off is what we know as menstrual blood.
Okay.
And then dropping levels of progesterone, which happens in the later part of the cycle just before menses, is the trigger for somebody to have a period then. So the higher levels cause the tissue to grow. The dropping of the levels cause the tissue to shed.
Okay.
Does that make sense?
That makes perfect sense.
Yeah. So, and then estrogen does a lot of other things, secondary sex characteristics, but also includes building up the lining of the uterus in preparation for pregnancy too. So that those two hormones do that. So I think what happens is that when women are like in their 40s, maybe late 30s, these levels are they're not going to zero, but they're kind of petering out. They're not at the same high frantic levels. And I think women feel that, although medicine doesn't necessarily respond to that.
So if a woman is in her late 30s, early 40s, and she's feeling these symptoms, but she's still on birth control or a low dose birth control, would that hide the symptoms?
Yeah, that's a complicating factor. So there's a number of complicating factors that might make somebody's trip to menopause a little bit different.
Okay.
So one of them would be being on oral contraceptives. And oral contraceptives, as an aside, are safe medications. They are something that women can use from the time their first menses all the way to the last menses. There is data available, like a lot of data available, looking at a woman's use of contraceptives even throughout her lifetime, like 100% being on them, taking them every day.
Oh, wow.
Yeah.
Okay.
And as far as side effects, you can mitigate risk factors. There's certain risk factors like high blood pressure, or perhaps age in cigarette smoking, that can make them a little more dangerous. So we can protect or kind of predict who's going to have problems with them, and then reformulate the pills.
Okay.
Okay. There's a lot of, when you say birth control pills, that's like 100 different types of pills.
So there's options based on
Right.
health and
Right.
okay.
And kind of exciting as an aside, there's a brand new progesterone only pill, which oftentimes women get put on if, say, they're over 35 and they're smoking. Then the new progesterone only pill is like super more effective and a real step forward, but it's basically unused up here for some reason.
That is weird since we have such a high smoking rate.
Right. It seems to me a lot of the providers that when I sit down on meetings and I go, why don't you use this, SLIND, it's called SLIND, not endorsing it, have no financial interest in it, and people just blink. Although if you were in San Francisco, it would be something that would be used regularly for probably the last 3 years. So there are new choices is what I'm saying.
Okay.
Okay.
Is that just provider preference or is that provider knowledge?
Not provider knowledge base.
Okay.
Okay. Often, obviously you can have a surgical menopause, so a hysterectomy, and that's where a woman goes into the hospital and she's, got everything she needs to reproduce, and she comes out of the hospital without her uterus and oftentimes without her ovaries. A total abdominal hysterectomy is the name that they use for when somebody has their uterus taken out and their ovaries taken out. And people can get just their uterus taken out, but I think during that process, the ovaries are a little like, hey, what's going on here? And they go into a little bit of, I suppose, shock, if you want to anthropomorphize.
They miss their buddy?
They don't know what to do. Their system is messed up, and women feel that. So, and they feel that in similar ways that somebody who was premenopausal and, starting to have their hormone levels drop would feel it. And then thyroid disease. This is important when a woman goes in to see her provider talking about maybe changes in her period or feeling hot all the time or mood swings or maybe changes in her weight. That provider should not just assume that that's perimenopause. Okay, that provider needs to do thyroid studies for that woman because thyroid disease, thyroids are, do you know what a thyroid is? It's kind of an interesting little gland.
I have yes and no.
Okay,
It does so much.
yeah, so it does so much. And a thyroid's kind of like an idle on a car.
Okay.
So if it's not working very well and not producing the hormones that it produces, then, that car is like stalling out at every stoplight. They're just not running efficiently. So, and a symptom would be tired or dry skin, constipation. Periods would probably become less and maybe even disappear.
So if it was just thyroid problems, could that mimic menopause
Yeah.
and
And
early
then-
menopause
Yeah.
or perimenopause, which isn't a medical thing?
Yeah. Or hyperthyroidism can make people have a lot more bleeding. It can make them be hot and sweaty all the time. It can make them be tremulous. It can make them have a hard time sleeping. And so that's kind of like when the idle on the car is jacked up too much.
Okay.
So the thyroid is the idle on the car.
And how do you approach that conversation with your provider? Do you just
Could you check, instead of saying, could you check my hormones, saying, I wonder if my thyroid is a problem here.
okay?
And a lot of women say that kind of in regards to weight. But that if somebody comes in and they say, look, there's, has a gynecologic complaint, thyroid disease is not off the table. A provider should be thinking about that. Blood should be drawn. Those are the hormones that maybe should be looked at.
Okay.
I have to say, as far as the other hormones, that, estrogen, progesterone, luteinizing hormone, FSH, those are all kind of interest, but we have to remember that we're kind of like the Smith River at maximum flood stage. Okay.
Oh, no.
and we're changing second by second. And if you check somebody's thyroid or somebody's hormone levels, you got that one drop of water at that one point in time. And it's not necessarily useful data to act on. Perhaps it needs to be repeated in 6 months and kind of see how it's going. So you're looking at the change over time. Does
So
that
if you're
make sense?
struggling with that, is that going to be offensive to your provider to go and say, "Can you please check it again in 6
Not
months"?
to a good provider.
Not so good. That's a good
Yeah.
point.
Yeah. See, you can say, look, I'm wondering about change over time. Because in my mind, I don't necessarily verbalize this, but I say, what's the delta? Delta is the scientific way of saying change. So what's the delta here? I wonder how it's going to change over somebody's cycle or over somebody's, next 3 months.
So 3 months or 6 months. So do it quarterly
3 months,
or do
6 months, it depends.
biannually?
It depends on the situation.
Okay.
It's probably just a thyroid stimulating hormone, which is the message from the brain to the thyroid to either kick it in gear or slow down. Probably is at least routine blood work once a year.
Okay.
Okay.
Bare minimum annual checkups.
Yeah, that's part of my healthcare maintenance panel.
Okay.
But any kind of like gynecologist or women's health, PA is going to be able to know this already. It's not like the patient needs to tell us, but the patient could need to remind us.
Okay.
Does that make sense?
So be your own advocate and
Yeah,
say,
be your own advocate, speak your truth. We might look at you for a minute wondering what you've read or what you're talking about, but eventually it'll get sorted out if somebody is really listening.
okay.
Okay. So PCOS, which is also a talk, that's polycystic ovary syndrome, is a whole future talk in itself, but that can change how things go. And remember that hot flashes can be caused in problems sleeping and probably changes in menses can be caused by other things. Okay. So, for example, changes in menses can be caused by pregnancy. Even pregnant women bleed on an irregular basis. It does happen. Or it could be an infection. A sexually transmissible infection can cause some of these changes. So make sure that you're going into it with kind of an open mind of possibilities.
Okay.
Because there really can be a lot. If you go into it with you already have a diagnosis in your mind because you've researched it and you're fairly certain that's what you have. You really aren't certain, not in a medical realm.
So until you have the blood test, until you know,
Right.
it's
Until you also get the knowledge of your provider
Okay.
and the skill sets. So that don't go into it. It's a big mistake to already have a diagnosis that you're adhering to because you miss so much.
so that's kind of like confirmation bias.
Right. It's exactly what it is. And
Okay.
I think I can say that to patients and I can say that to myself and the message shouldn't be that you're ignorant, you're dumb, I'm so smart. No, it's just,
Yeah.
I have great resources and I'm willing to bring them to help you if I understand the question being asked.
Well, that you can order the test to confirm it.
Yeah, that's what I'm saying.
Yeah.
Resources, yeah. So after a woman goes through menopause, her whole focus of her healthcare changes. So before menopause, it's contraception, okay? It's STD prevention. It's maybe obesity would be an important thing.
Okay. But you're not suggesting that after menopause you're not at risk for STDs.
Yeah. No, I am.
Oh, okay.
I'm not suggesting that.
was like, that
but
doesn't
but when we go into a room, I don't know how to explain it. When my MAs first tell me there's somebody waiting in room 5, I want to know what the age of that person, what the gender is, and that opens a book in my head.
Oh.
And I go to the chapter that's likely relevant to them. And I can go to other chapters
That makes
to get
sense.
more information,
okay,
but
I
that's always
understand.
the starting point. Okay. But after women go through menopause, then they have significant and growing interest in their bone health. And this is where the Del Norte thing is kind of where we don't really have a resource. As far as I know, we have one DEXA scan, which is the scan you get to screen for osteoporosis or osteopenia, which is thinning bones and then
Okay.
definitely thin bones. And that's in Dr. Blundell's office. And as of June 1st, he's supposedly retired. And I don't know where that scan is going to end up, although I do know a lot of people are interested in buying it from him.
Well, I hope somebody locally buys it.
Right.
So essentially, if you need one, you either have to get it
You have to
from
go
the new owner
out
of
of
the
the
scan,
area,
or you
probably
like everything
humbled,
else.
and considering what insurance you have. Insurance limits us oftentimes to California.
That is true. Anybody on Covered California has to stay within the state of California for care.
Right. Same with partnership.
And I think a partnership will allow you to cross the border on occasion
For emergencies, but
Yeah.
and maybe Asante, Carrot Asante.
Yeah.
But that wobbles. Some months it's on and some months it's off.
It's very true. Partnership is definitely one of those tricky
Right.
things.
Right. For postmenopausal women, there's an increased risk of cardiovascular disease. So, this risk.
How much more increase of risk for postmenopausal?
It depends. It depends on the person. Sometimes it's hardly any, and sometimes it's a lot. But this particular risk, we always assumed that women didn't really have a cardiovascular risk because estrogen protected us. And then there was that study, I think it was about 20 years now, and I can't really quote the title, but they compared Premarin and Provera, so a combination hormone supplement that a lot of women take postmenopausal, to just Premarin as hormone replacement for women that didn't have a uterus.
Okay.
And what they found, what it sounded like to the average consumer was, these drugs will make you have a heart attack or a stroke. But the real finding in the study was the combination drug, Premarin and progesterone, can increase your risk for heart attack or stroke. But the the arm of the study that was estrogen only, so Premarin only,
Okay.
didn't see that. And so,
So why is there still that misnomer out there that if you can only take the hormone replacement, that's what we're talking about, hormone replacement therapies?
Right. Mm-hmm.
You can only take it for such a short period of time, and then you have to suck it up and deal with all your symptoms.
right, I think that was misogynistic, because
It
that's
sounds
not,
that way.
That's not what women gynecologists did. Okay, so what they did oftentimes was they went on a different kind of estrogen and a different kind of progesterone, and we haven't seen that for them.
Wow.
So you might, if you have a postmenopausal female provider, you might ask what.
Well, I
what
have
she
a
thought.
female provider now, but it was male providers before,
Yeah.
and I was only given the HRT for
Right.
a year and a half, and then
Right.
told I was going to die of a massive heart attack or stroke if I continued to take
Right,
it.
that's not true. So there's other ways of looking at it. So
That is incredibly frustrating.
what this study does is it makes that conversation personalized.
Okay.
That you can't go in there and lay down some universal law. Like you have to say, you have an increased risk of this and this, but a decreased risk of this and this. And, for me, the bugaboo of growing older is dementia. I'm really afraid of dementia. So hormone replacement therapy can decrease my risk for dementia.
Really?
But my risk for cardiovascular disease and bone health is minimal. And it's not in my personal closet of terrors. Okay, dementia is, but not heart disease and not breaking my bones.
Yeah, my mom used to say she wasn't afraid of dying. She was afraid of the process of getting there.
Right.
So that makes sense to me.
So I think the discussion has to be personalized, and the woman has to say, look, this is what I'm really afraid of.
Okay.
And, but this, my risk is low. My family's been healthy. My cholesterol is well controlled. I hike a lot, so my bones are in good shape. Meh, not so much a problem. So, and
Okay.
remember that estrogen and progesterone is like saying apples. There's a lot of different kinds. So what we know from that study is Premarin and Provera, those are brand names, were the problem, but not necessarily the other ones. Data is ongoing. It's not clear. yet.
Okay.
So skin changes too. It's important to understand pelvic floor health, and that's something that's been overlooked in women for a long time.
Okay.
But now we have physical therapy, and we have different modalities that we can help women with that.
There's physical therapy for pelvic floor health.
There is.
Wow.
It's in Medford, unless you're in the UHS system, and then their physical therapy department has somebody who's experienced in it and willing to do telehealth.
Oh, wow.
So super exciting. So
talk to our native sisters and find out how to do that.
yeah.
Okay.
Yeah, or you'd be willing to go to Oregon. But but this, the end of this discussion, I think, brings a good health matters topic, is that I'm all on fire about women's health right now. I have been a women's health provider for a long time, although my interest is internal medicine and infectious disease and pregnant women and peds and emergency room and acute care and about everything else.
All of it? Yeah.
Right. So, but I'm kind of on a tear about women's health. So I'm hoping that we can take health matters kind of in that direction a little bit more. So look for that this summer. I don't think I'm going to be doing it weekly, but I think I want to talk more about things like contraception, which is kind of a Del Norte weak spot. Anyway, we can get into that later, but I'm on fire about it, so that's exciting.
Sounds like that is exciting. I'm excited to bring
PCOS, breast health, perhaps. What the difference between the two mammograms, the one at Sutter in town here and the one at Sutter in Brookings. What's the real difference? How should you make a decision about which way to go? All of this.
Wait,
is super important.
see, I didn't even know there was difference in mammograms.
They have high density, and what's the trade-off for that? It's
Wow.
not necessarily better.
You
for
think
some
being
women.
female for 50 years, I would know more.
Yeah, so I'm about addressing that. So we'll
I am
talk
all
again.
about learning about that, Lynn.
Yeah, we'll talk again.
Absolutely. Thank you so much for being here. This is Health Matters with Lynn, our resident physician assistant. I appreciate you being here. Thank you.
Bye-bye.